Thank you very much for inviting me to this interesting webinar. I already learned a lot, actually. And my task, as you said, is to discuss today if we need real-world data to support the concept. And actually, why do we need real-world data when we have all this evidence from randomized clinical trials? I guess that the real-world data usually serve to generate hypotheses for future randomized clinical trials, as the association between cardiovascular disease and psoriasis was found through real-world data. But also subsequent to the randomized clinical trials, we usually need to generalize the results from the randomized clinical trials to include not such usually biased groups of cohorts that are tested in the clinical trials, and maybe also extend to new endpoints. So how do randomized clinical trials and real-world evidence data differ? I mean, like Joel said, the randomized clinical trials are superior because they include randomized patients and the study design is stringent and you can really draw conclusions from them. But usually selected patients, and they cost a lot of money. If you want to do long-term clinical randomized trials, it costs a lot of money, and the external validity may not be so high. The real-world data, of course, has better external validity, and you can generalize better with a better mix of included patients and have large patient materials. But, of course, the lack of randomization is a real drawback, and the risk of inadequate study design is also a concern. And usually, if you want to do large trials, you have to combine multiple, maybe non-compatible data from different sources. But as I said, real-world evidence has really generated the hypotheses that have been studied and verified the disease, the connection between cardiovascular disease and psoriasis. The seminal paper from Joel, of course, we all read that in JAMA, and also meta-analysis. This is an early one from April Armstrong's group, but there are also later ones that go through the real-world evidence data. The mechanisms between cardiovascular disease and psoriasis are still not completely clear, even though today I learned some new things about thrombocytes from Michael here, very interesting, but I think it's a mix of different factors, including both lifestyle factors and cardiometabolic factors, and also all the immunology. And I guess that to design the clinical the real-world evidence studies, a better insight into the mechanisms is very important. So the question is that, can effective anti-inflammatory psoriasis treatment reduce cardiovascular risk? From the randomized clinical trials, it seems so. I'll share with you some data on real-world evidence and start with a Danish nationwide administrative data. You know that the Scandinavian countries, they have a real wonderful tool when it comes to epidemiology. We have the personal identification number. Each individual is assigned a unique code that you can trace individuals through huge administrative databases. And you can concentrate on the healthcare. You can get data on medications and comorbidities, causes of death, etc. So that is a unique opportunity that this Danish group, Alehoff and colleague, really exploited in two early studies, actually, one in 2013 and one a couple of years later, when they did a follow-up of the same databases, actually. In the first study, they compared biological agents with methotrexate, and they could see that there was a protective effect from treating patients with biological agents, methotrexate, compared to traditional systemics. The other study expanded on this. It was longer, 5 years, and they compared with cyclosporine, retinoids, and also UV light and phototherapy that was actually used a lot in those early days. These are early studies and the number of patients are not so many, but a few hundreds at least. And here we could see that methotrexate and the biological drugs were rather equal, even though methotrexate in this study was superior to the biologics. The authors did an interesting sub-analysis comparing anti-TNFs with interleukin 12-23, ustekinumab. And they had not so many patients on ustekinumab, but you could see that the protective effect attributed to the biologics came from the anti-TNF treatment and not from the ustekinumab treatment. This is sort of, there has been a spotlight on interleukin 12-23 when it comes to cardiovascular risk. And as Joe alluded to before, we need to study all these drugs, I mean, all the biologics now, and all the small molecules that are coming in different, with different targeted effects separately. The strength is the long follow-up and the nationwide coverage, but these were early days for biologics, not so many patients. And there was also a selection bias when it came to recruiting patients. They were younger, there were more men in the biologic session, and they had limited data on potential confounders, even though they could retrieve a lot of data on comorbidities so that they could adjust their data to reduce some of the bias. The next study is a large study from the British register. They have a national register that collects all patients on biologics, the BADBIR. And the aim was to study the different biologics and in terms of safety for cardiovascular events. And they had quite a few patients, more than 5,000 patients. And the majority of those were anti-TNFs. And in the main study, they compared anti-TNFs against ustekinumab. And then they did a sensitivity study comparing all the different biologics to methotrexate. And they were able, because this biologic register contains a lot of clinical data, so they were able to create a surrogate for randomization, a propensity score, so trying to make the different cohorts as equal as possible when it comes to comorbidity and other factors that would influence the selection of treatment. So we can see here we have clinical scores for disease severity, we have PASI scores, we have all the comorbidities, we had diabetes, and we had smoking and alcohol. So they had quite good ability to compensate for and to adjust for the difference in the different cohorts. And here we can see the data comparing IL-12-23 versus anti-TNF, and the blue dots are before adjustment. And here we could see that IL-12-23 would seem to have a higher risk for cardiovascular events. But if you do the adjustment for these factors that actually influence the selection of treatment, you can see that this difference disappears. It seemed like a patient who had diabetes, who were obese, they were more selected to receive anti-IL-12-23. So that's why they ended up with a higher cardiovascular risk. So it's very important with the adjustments, and that is a real challenge when it comes to real world data. And now I'm moving to another strategy that has been used in particularly in countries where we don't have access to these big databases. And these are studies on health claims data. And I will talk about two studies. They come from J.J. Wu's group. And in the first study, he compared the anti-TNFs with methotrexate. Already here, we can see that there is a bias in the selection of treatment in the anti-TNF group. There were younger patients and more men. And of course, there is a complete lack of clinical assessments. Even if you get a lot of data on comorbidities and medications, because this is something that you can tease out of the health claims databases as well. And here we can see that there is difference, especially if you in the I can't see my slide myself because I have all these images hiding them. Try to get it out. We could see the odds ratios here, that they are significant in all these different cardiovascular events, the major, the stroke, and the myocardial infarction, but also in the unstable angina. So there is an effect. In the next study, okay, see here. They also, no, in this study, they also looked at the cumulative exposure for anti-TNFs, and you could see as time goes on, number of months after the study started, you can see that the difference between the anti-TNF cohort and the methotrexate cohort increases. So here we can see that we really have a positive effect of anti-TNF treatment. Here. And in this study, they compared also, in the second study, they compared different groups, the anti-TNF group against oral phototherapy group and topical therapy group. So I guess the topical therapy, there were a lot of patients there. We don't know about their psoriasis severity, but of course they must have been much milder than the ones that got anti-TNF. So, and they were the reference group, and the anti-TNF group sort of beat both of these groups. And the final study that I'm going to talk just a little bit about, because Joel already mentioned that, the study comes from him and from Nihal Mehta, using these high-risk coronary plaque as a surrogate marker for cardiovascular events. And it's a small study, but it's actually, these patients were followed for 1 year, and they were all naive for systemic therapy when the study started. And in the final analysis, there were 89 patients that received biologics. And here we also see some patients on anti-IL-17, anti-IL-12, 23, and anti-TNF. And a smaller group received only topical in UV. And these patients had extensive clinical examinations, of course. It was a collaboration between cardiology and dermatology, and also extensive imaging data with many, many arteries investigated. And the high-risk plaque is the non-calcified atherosclerotic plaque, as we have learned, is really a marker for cardiovascular risk. And here we can see the changes in the biologic group and the non-biologic group, and the number of arteries that were imaged. And we can see that it's both the total plaque burden is decreased in the biological treated patients, and especially the non-calcified plaque burden is decreased, whereas the dense calcified plaque burden is unchanged, actually. So this is really hard evidence that high-risk plaque are decreased through treatment with biologics. So this is, of course, very resource-intensive investigations to perform, but gives a very important evidence. And if you can do it in more patients, that would be very interesting. So what should we think about when we design these randomized, real-world evidence studies? I mean, ideally, the study should include the mechanisms for the association to cardiovascular disease. So is it the skin inflammation? Should we follow the skin inflammation with PASI, or do we need biosamples to follow all the inflammatory markers in circulation? And I mean, it would not be feasible to take out the endothelial cells from the brachial arteries in too many patients, you know. But also we have to, it's this combination effect, we have to take into account all the known risk factors for cardiovascular disease. So I guess we need to have all the data on these patients if we're going to come to some conclusions. So there are many challenges, but I guess we need large cohorts. And there is the challenge of harmonizing data from different big databases to be able to generalize the results. But we would like to generalize the results because we would like to have data from different populations. Also need to investigate more in detail the different classes of drugs, but because it's evident that these targeted treatments may affect the cardiovascular risk in different ways. And also, ideally, we would like clinical evaluation of the patients and mimic randomization with these propensity scores, or maybe even some other fancy statistical methods, because this is, of course, important. We can see that the data and the results can change completely if you adjust for these factors. I will just finish showing Karolinska in the summer. It doesn't look like that now. We're in the middle of winter and it's dark. This is how the new buildings compete with the old ones. Okay. So, thank you.
Thank you very much, Mona.